I want to get us started on our conversation with global health leaders. And these are people who many of you know. In fact, our first panelist is someone that those of you who follow Devex, who attend our events, who read our pages, know very well and need no introduction whatsoever. But Dr. Agnes Binagwaho is with us from Rwanda. Agnes, welcome to this discussion. You are, of course, the former Minister of Health of Rwanda. You spent a long career since you went back to the country with your MD and your PhD to work in the healthcare field, rising through the ranks to become minister. After you left, you helped to co-found the, of course, well-known University of Global Health Equity, which I had the honor to visit last year. And you work with partners in health. You wear many hats, including as a senior advisor to Dr. Tedros at the WHO. We always love to get your take on these issues, so thank you for being here. And let me also welcome Dr. Mickey Chopra, who leads service delivery at the World Bank in the health, nutrition, and population global practice. Mickey, thank you so much for being here. You, prior to this role, were the chief of health at UNICEF and have spent a long career across many of the global health institutions we all know so well. So thank you for being a part of this. And then I see Dr. Emanuele Capobianco is with us as well. He directs health and care at the IFRC, the International Federation of Red Cross and Red Crescent Societies. He, at the IFRC, leads their COVID-19 response, as well as the Ebola response in DRC, another crisis we can't forget is still happening. So thank you as well for being here. And I just want to jump right into the discussion. Maybe I can start with you, Agnes, and get your overall take on where we stand. This was supposed to be 2020. Dr. Tedros and WHO said was going to be the year of the nurse and the midwife. Of course it is, but COVID has taken over everything. Give us your take on where the healthcare workforce issue sits in the moment that we're all facing today. And I think you're on mute if you're talking. Let's see if we can unmute Agnes, please. It seems like she is still muted. Not yet. Not yet. Yep,
I hear you. You hear me? Sorry,
we hear you now.
I lost
we hear you.
even. That's the IT mystery. I don't want to question my computer. But, it has to be still the year of the nurses because they pay a huge tribute. And if we go to the fact that the health is a human right, everybody is entitled to that because they just exist. So we all accept that access to medical assistance when you are sick is a human right. So it is a moral obligation for clinicians, nurses, doctors, community health workers to serve the patient when there is a need. And during pandemic like this, there is a huge need. But the problem is that if they are not protected, I talk about the nurses, the doctors, the community health workers, the lab technicians. If they are not protected, they may die. And there are so many victims of the service because not enough PPE, not enough masks, or wrong message, or really not caring about them. The year of the nurses. So I'm still shocked with what happened in countries that can afford. Some country maybe are not able to afford, but the majority of the country, it's not the case. And they say it happened by surprise. No, the big peak out of China came 4 months after. So there are countries who were prepared and there are countries who were not prepared.
And Rwanda fortunately falls in the category of a prepared country. At least so far, the virus has not grown too much in the country. You stopped very early. You very quickly had a lockdown, stay-at-home orders, and the country seems to be doing very well in comparison to many others, especially here in the United States, which leads the world in infections right now. Agnes, let me bring in a couple of our other voices. I want to come back to you in a moment, but Mickey, maybe we can turn to you at the World Bank. Agnes said it's a moral obligation, and yet she's right. So many countries haven't been able to provide PPE. They haven't been able to, even before this pandemic, expand their healthcare workforce in the level required by the demands, especially of growing non-communicable diseases. Many community healthcare workers in the world still aren't paid. They don't get a formal wage. How do you see this issue of healthcare workforce that you work on all the time before the pandemic? How do you see it affected by this pandemic?
Yeah, Raj, that's a great point. And sometimes we forget this, that the pandemic, as Agnes has said, in many ways has just amplified the fault lines that were there before the outbreak. And, you know, it's no surprise that countries where the investment in health workers has been too little and too low, and the trust between health workers and management and employers has been shaky, have been the countries which have really seen the system most fragile. And so I do think it's right to draw attention to these pre-existing conditions, if you like, that are making some systems more vulnerable. And as you indicated, it does range in the first instance to financing. And an issue which I want to bring to the table as well is the real concern we have that even before the outbreak, that the financing conditions in many countries was very fragile in terms of debt, high levels of debt of many countries. And then now with this outbreak and the recession, the fiscal space for investing in health workers has become more and more endangered. And so I do think the role of an organization like the World Bank is first and foremost is how to expand that priority given to healthcare workers and the health systems in the context of really tightening budgets and tightening fiscal space. As you may know, we've sort of started with at least getting about $160 billion out in terms of grants and concessional loans on the COVID response to about 100 countries. But that's just the start. It's then, you know, translating those finances and resources into equipment, but perhaps most critically into behavior changes as well, is how to build that trust in the system and with the health workers as well.
Yeah, and it's kind of ironic because you're saying correctly that right now many countries say, hey, we don't have the fiscal space, our economies are in recession, they're heading down, and probably what they've lost in their economy is more than what they could have just invested into having a stronger health system to begin with that would have mitigated such a severe economic impact. And in the end, even numbers as big as 160 billion could look very small compared to the scale of the economic devastation that this causes.
Exactly right, Raj. Yeah. So how do we make that investment case stronger and more powerful and amplify that voice that you've got sort of through the Devex partnerships, for example?
Yeah, Emanuele, you were grappling with Ebola in DRC. You know, like a lot of other disease areas, this is one that got a lot of attention in the beginning. Then the public attention started to fade. Healthcare workers in that country were under attack in many cases. You know, the situation was really difficult, still is. What lessons are you drawing from that and from the pandemic at this point?
One of the first lessons is that you can't control an epidemic without having the people with you. This was very clear in Ebola in DRC on the East Front in North Kivu, where we did have vaccines, where we did have a treatment in place, and yet it took us 2 years to bring that outbreak to an end. You transfer this into our reality and you see that we have less weapons, but still you can contain a lot the outbreak if you bring people with you. And that is happening in some places with the right combination of harmonization of politicians, scientists, and media coming together. It's not happening in other countries. One of the critical elements for us in the Red Cross is epidemics need to start with people and will end with people, and people needs to be kept at the center throughout. And that's where I think one of the biggest lessons from me, from Ebola and from this, is the importance of community health. We have talked a lot about doctors and nurses in hospitals. These are the heroes, and rightly so. We have talked less, and I'm glad that you showed the video about our community health workers in Uganda. We have talked less about the frontline health workers, about the challenges they face. And it's not only the physical protection of masks and PPEs, it's also the psychological protection. The amount of stress that they have endured, that are enduring, is enormous. It also the financial protection. Many of those ones are there risking our lives without hazard pay, without health insurance, without death insurance, and they are out there compromising their own, risking their own lives and the lives of their own families. We need to reconsider that for the future and bring that now to the center of our policy discussions for managing this pandemic, but also preparing for future pandemics, future global health challenges that will require a very strong community health basis to respond.
Yeah, it makes me think of the West Africa Ebola crisis and the importance of just getting pay into the hands of the healthcare workers, using cell phone, mobile money, because in the end, healthcare workers themselves and their families can be very vulnerable to the virus or to, just the economic repercussions. They need to eat. And if you don't pay them, what are they supposed to do? Agnes, I wonder what your take is so far in the conversation. When you've been in all these global fora, I see you all over the world pushing governments, pushing the international organizations to make investments in healthcare workforce or in healthcare systems in general. And now here we are talking about trillions of dollars of stimulus. The European Union just passed 800 billion euros. The US government's talking about another $1 trillion package. All this money sloshing around. Is any of it coming to the places that you know so well, like where the University for Global Health Equity is based?
I'm even not sure. I don't know how to trace this money, but I'm not sure that it's going at the right place to do the right thing. And what has been said before, that if this money have been invested in 2003, there was a great Lancet Commission on investing in health, showing how the investing in health even accompany development and is a big portion of development. Every dollar invest in health, but with equity. We have to be careful what you meant when you say investing in health. And I totally agree that health starts at community level, where the people live, in household, in a village. And if you invest the right amount, and it's sometimes not so much compared to what is planned, but they are not considered. And we talked also about trust. Investing in ICU, we all need ICU, all countries need that. But investing in community health allow a country like Rwanda that has only 5 deaths, and among them 3 coming from outside, too late, to perform as we have performed, investing in community health, be prepared with your infrastructure, and also be responsible of your job. When the China was screaming, it's dangerous, we start to work in January, got the first case in March, and be ready to tackle it. Other countries knew they didn't move just because there is a bridge in accountability. So no, the money doesn't go where it has to go. And there is no accountability, there is no financial accountability, and there is no long plan development of the world.
And this is obviously a major systemic kind of a challenge. We at Devex, we had produced a report in partnership with PATH back in 2017, where we interviewed a number of people, including Dr. Anthony Fauci, the US lead doctor for infectious disease, and said, what are you most worried about when it comes to global health security? And the number one issue that everybody, 40 people we interviewed, all said was a respiratory influenza-like pandemic and how dangerous this would be for the world. And yet, it was all a big surprise, and we keep hearing the word unprecedented. The global health community says, no, we knew this was coming eventually, we didn't know when, but we knew it would come, and we needed to prepare for it. Clearly, we haven't quite gotten there. Mickey, you talk to a lot of the health ministries in the world, people like Agnes in her former role. What are you hearing from the health ministries? Do you think things are different this time because of the pandemic in terms of the way they view their health workforce, the investments they might make? Has something really changed in a more fundamental way?
Yes, I mean, two interesting things which are coming through quite clearly. One is the recognition that the supply chains to provide these PPEs and to provide the infrastructure are broken. and have been much less resilient than people had thought. And so I think there's a recognition of the need to not just invest in safety and health workers, but also that how vulnerable we are to these global disruptions. And so I do think one of the recognitions has been to not just look at it from within the health sector, but engage with the trade ministry, with the, so in Ethiopia, for example, we've been having discussions about giving tax subsidies to the textile manufacturers to produce PPE, to waive the import tax on cotton and things for production of PPEs. So I think there's a recognition that this goes beyond just the Ministry of Health, and that there needs to be a more joined up thinking of how to tackle this issue. I think the second recognition, which I suppose is a little bit of a dirty little secret in global health, and ministries of health are recognizing this more and more, is that actually in some countries, the terrible quality control and infection control in health facilities is actually a major cause of spread of the disease, and the lack of both sanitation and water facilities is scandalous. But also that the infection control procedures in many health facilities across the world are just not being adhered to and have never been adhered to properly. So I think there's also a recognition that this is not just a nice or good thing to do, but an essential thing to do to control this outbreak. And so I think this sort of combination of the importance of this, but also some of the non-financial challenges are also becoming higher on the agenda.
Yeah, one of the articles you'll see on our Duty of Care content series mentions that 55% of health centers in low-income countries don't have access to clean water for hand washing for healthcare workers. It is, the word scandalous is absolutely right, Mickey. It's shocking that we could be, even before a pandemic like this, in such a situation. And then you wonder how they're meant to follow infection control procedures and how they're meant to be hygienic in a situation like that without such basic facilities.
Absolutely, and maybe something we'll come on to, Raj, but this then has secondary effects, because then the population, as Emanuele was saying, as we saw in the DRC, loses confidence, quite rightly probably, in going to the facilities. And so we're going to see these second wave effects of increases in non-immunized kids, in maternal deaths. It took Liberia over a year to get back to its pre-Ebola situation in terms of maternity and institutional deliveries, for example. And that was with huge investments in the system post-Ebola. So the lasting impact of this outbreak could be more than just the direct impacts of COVID, but the loss of confidence of the population, exactly because of this lack of, people see it. When they go to a facility, they see that there isn't those infrastructure there, and they're not stupid. So so this is not just about the direct impact, but also the indirect impact and longer term impact as well.
Yeah, you could see that as a subtext of the Prasi interview we did, the community healthcare worker in Uganda, because she's saying, look, I'm not going out because I don't have enough PPE. People have to come to me. Well, that's got to reduce the demand. There has to be a big demand shock. I saw that from one of the participants in our Twitter chat, that a lot of people are just simply not going to healthcare facilities for other kinds of illnesses because they're worried. And I'm sure the number of people she's able to see as a community healthcare worker must have gone down dramatically, and that will lead to less prevention and more healthcare challenges down the road. Emanuele, I think you wanted to jump in on this point.
Yeah, clearly the secondary impact on health are going to be enormous. In the rich world, we may see that elective surgeries are being delayed. We may see that testing for cancer may be delayed, and that's what we may have seen within our families or of our friends. What is happening in a lot of low-income countries, that immunization efforts are being halted. You have TB patients that are not coming to the facilities, and hence we have projected mortality that is extremely high. And so we really have to face a double challenge right now to respond to COVID. And you have these frontline health workers that need to respond to COVID, while at the same time providing services for the other critical diseases that require primary health care. And that is a massive challenge. And that builds on a basis of limited workforce that then becomes exhausted and then gets into burnout. And that's where I think one of the main outcomes of this crisis will be the realization that mental health and psychosocial support is not a byproduct, is not something that goes really at the last priority, really needs to be put at the very top. That's something that we at the Red Cross are taking extremely seriously. We passed at the international conference in December, the largest humanitarian conference, 2 resolutions. One was about epidemic and pandemics, preparing, and it was called Time to Act. And the second was about including mental health and psychosocial support as part of all humanitarian initiatives for the people who may benefit from the services, but also for the health workers and the volunteers that are involved. And that is something that for us is critical. And we have seen mental health and psychosocial support really emerging as a top priority within the larger priorities of the direct impact of health of COVID and indirect.
I think Agnes wants to jump in on this point, please.
Yeah, I totally agree. And this is in situation of crisis. But this has to be the case in day-to-day work of a country. And what we teach about the staff, the space, the staff, the system, and the support as a basic way to provide care, integrating everything. It's what we call about now we can do nothing if we don't follow the truck drivers. And this is the Minister of Transport, and the custom is the internal affairs and security. So national collaboration, but also international for exchanging the good practice and what happened, and everything community driven. So everything said here should be the day-to-day work of a normal health system and create a system with trust and accountability. So I just want to say that because it's not when there is a crisis that we discover the good principle of global health. They are there, they are known. We are screaming it since years and we are teaching them.
Yeah, I just want to go back to something that Mickey said, which struck me. You know, he's talking about working with the trade ministry in Ethiopia, getting, reducing taxes or tariffs to manufacture PPE. And that's obviously it's going to take time to set up manufacturing facilities. But the reason you would do that is because this is not over anytime soon, right? I mean, the best, Bill Gates was saying just a couple of days ago, I think that the best case is still end of the year for a vaccine. That's the best case. And of course, will that be available in many of the countries we're talking about that are low income? Not for quite a long time. So PPE is going to be needed for a year, 2 years, a very significant amount of PPE as well. And a lot of the systems changes we're talking about, there is still time. In fact, there may be a lot of time that we're still living in this pandemic crisis moment where big change is possible. And so I want to just say that as a prelude to one of the questions, we're starting to get great questions in from the people who are following this all over the world. And one of the questions is, do we need to really think bigger about some kind of a reboot of the overall health system? In other words, should we just be rethinking and using the currently available resources differently, or do we need to really think about radical disruption in the health system?
Absolutely. And if the health system, we will analyze countries who have performed well. They all coordinate across sector. They all coordinate with their partners. They were all community driven. And in those countries, like in Rwanda, there is no disruption of primary care. They all have built their COVID response successfully on a strong primary care system. And if it's not there, they have to build it because tomorrow there will be another one. The second thing you say, we should start now to think about all the developing countries starting little factories to respond to the need of the country, like we do here. We have started producing respirator locally. We start producing PPE locally. We are going to make error, etc., but we will be ready for the next pandemic.
Other thoughts about this big picture question we're getting, Emanuele, about do we need to really rethink, reboot?
I think if we look, Raja, the experiences that come from SARS 2003, and we look at Ebola, there are a couple of lessons. If you invest in preparedness, those countries that were hit by SARS in 2003, particularly in Asia, that will pay off. Maybe 15 years later, but when the big meteorite hits, you are ready, and they were ready, and they have been able to really contain the damage. And so preparedness is one big thing.
And Emanuele, just to not to cut you off, but just to your earlier point about community and trust, a big part of that preparedness has been those Asian countries where the population says, I understand what this is a risk, I'm going to wear a mask. You don't have to tell me twice, right?
Indeed. On my note, preparedness and communities are the 2 points that actually I wanted to make. Invest in preparedness, invest in communities. And as Agnes was saying, it's so much more difficult to invest in communities and in a response, during a response. You need to do it before. And I have a bit of hope in the fact that for Ebola, we had a lot of innovations that were actually put in place in West Africa that became reality. They were just embryos there and became reality in DRC. I hope we're going to do the same, and we'll be going through this, innovating and then growing for future epidemics, pandemics, realizing that this type of collective solidarity, is understanding that no one is safe until everybody is safe, is something that doesn't apply only to epidemics and pandemics, and we'll see more in the next decades. Is something that applies also to antimicrobial resistance. Is something that applies also to climate change. So what we do have now is an opportunity to really radically rethink our world and our health systems around preparedness. As Mark Dybul used to say, we should be talking about systems for health. So health systems and community systems, and all our systems for health. And working at the 2 levels, the community system and health systems. My understanding after years of working in this field is that we have invested a lot in health systems. The community systems have always been the forgotten child. Now this has to change, and this is the opportunity to really invest heavily in communities and in preparedness moving forward.
Mickey, what do you think about this? Emanuele is saying a radical rethinking. Are you of the same mind?
Yeah, no, I think for sure, I completely agree that the opportunity this brings to refocus on health, but not. So the first shift I would suggest is the one that we talked about earlier, which is with the ministries of finance and leadership, that health is an investment and not an expenditure. And getting that recognition that, as you said, Raj, that we could have saved ourselves trillions of dollars if we'd made that investment, instead of finance ministers looking at health as just a sinkhole of expenditure. So that shift in mindset at the leadership level of health as an investment in the future is going to be one important shift. For
Mickey,
sure,
just quickly, is that more of a kind of a long-term versus short-term thinking change that's required, right? If you're a minister of finance and you're saying, I need to get revenue now, I need to find ways to improve my budget picture now, versus maybe saying, well, if I invest in healthcare, prevention, primary health, that might not pay off while I'm finance minister. It might be 3 finance ministers from now. Is that part of the challenge? Or do you not see it that way?
But as you said, I think our challenge is to present that there are some very quick wins that can be made, which will have, and then the examples that Agnes and Emanuele are given of countries which have very quickly and quite rapidly, and the SARS experience in East Asia is a classic one. These countries, South Korea after MERS just a few years ago, invested in putting some of these systems and now reaping those rewards just in a very few years, within the lifespan of a finance minister even. So I do think we need to, you're absolutely right, be smart about how we position this. It's not just as a lifetime investment, but as an immediate investment, which will have quick quick returns. And then, as I said, the other area, in addition to the focus on primary and getting down to the community and building that trust, I would add the other aspect, which is very exciting, and you alluded to one of them, is the use of mobile technology, the e-payments, of being in touch with community workers, even in the most peripheral areas. So these investments could accelerate the use of innovation and of technology to really, to get a system which we learn from the challenges we've had in the past, when we've invested heavily in large numbers of community workers and often not got those same returns just because of the challenges of managing such large programs. So I do think this is a chance to look at ranging from telemedicine that we're seeing in many African countries through to e-payments like in Sierra Leone now. Community workers are being paid through mobile money and managed remotely as well. So
we have
big opportunities.
We have an article in the Study of Care series about frontline healthcare workers that talks about the use of robots during this pandemic, and I believe Rwanda has been using robots. And of course, these are the kinds of things that maybe are the cutting edge, or maybe just the example that isn't the usual use case. But nonetheless, it feels like this could be a moment when the urgency is so great, the need to move so quickly is so great, that maybe you could actually get faster technology adoption. I'm curious what all of you think. Do you expect that we'll see more of a digital health system in the future, just in the next 12 to 18 months? Or do you think, Emanuele, you're working in places like DRC, connectivity is an issue, electricity is an issue, or do you think this is kind of pie in the sky and not likely to happen in the countries we're mostly focused on?
Thanks, Raj, for these questions. I happen to be on the Financial Times Lancet Commission on Digital Health, and we just ran the IFRC last month a huge consultations around digital health in humanitarian settings, where this was really at the center. And I think there are a couple of messages that came out. Yes, digital health technologies have an enormous opportunity at this point in time, but they need to be, particularly if we think about difficult settings, they need to be simple, cheap, able to work offline, sustainable, and having somehow a way to remain. Otherwise, the risk is just having a pilotitis, an immense exponential growth of pilots that actually do not have mass. The other points that came out of the consultation that was very interesting for me to hear is there was almost unanimous agreement that technologies are 20%, people are 80%. While you do have technologies, you need to make sure that you do have the people that actually sustain and make the technologies happen. And what was being brought forward was the issue of contact tracing. There was a lot of hype at the beginning over the past several months about contact tracing, which are actually tracking apps. And yes, they are helpful. But the contact tracing is a human-to-human relationship that requires trust, the trust that Agnes recognized earlier. And technologies cannot eliminate that element of trust. So can simplify certain transactions, but health is a lot about trust. And we need to, while we move on technologies and we support that, we need not to be swayed too strongly in that direction, because the risk is that then we lose the human side. A vaccine is a good technology, can save lives, but if you don't build the demand, the acceptance in the communities, that vaccines will not be able to save people, because will not actually reach the arm of a child or an older person in a community.
Agnes,
can I say something? For the trust, remember this country. 25 years ago, it was totally upside down. 1 million people killed by the neighbors. And today, if you look at the Wellcome Trust survey of last year, Rwanda is the country with the highest trust in the health sector. And we have a so non-finished health sector. I have to tell you, how many respirators do we have, etc. But people trust. And because of that trust, when we stand and say we need masks, people have, even some of them never saw a mask up country. They will list you, ask question, and put the mask. And this is what makes the difference. And for vaccine, it is the same. And for robot, is the same. You can see we have robots now. We are preparing. I was watching this morning a reportage on the opening of the airport, what is coming, with robots circulating and tell to people, wear a mask, you see. And also taking the temperature so that you decrease the contact. You can use technology to improve care surrounded with trust is good. There are some countries where there is this hub for contact tracing. People stood up and say, my liberty, I don't want you to follow where I'm going. If you do that in Rwanda, because people know that it will serve them, it's not because they are just following without thinking. They just say it's a very good way to decrease the burden, the human burden, and to improve the health of the population. Trust is a social determinant of health, of education, and of development that is totally neglected.
Yeah, it's interesting. We had a question come in about the private tech companies and how they can play a role in this. And when you think about how much they have grown given this pandemic, right? I mean, if there's any beneficiary, it's the biggest technology companies in the world. We're all on these video conferences, right? And you look at their stocks, they've rebounded and gone to all new highs. I think it's 15% of the world stock markets are now, the value is just 5 companies, the biggest 5 technology companies in the world. And yet, when you talk about trust, a lot of the trust problem is the spread on a lot of technology platforms of misinformation, of conspiracy theories, of people telling you things that are opposite to what the health authorities are telling you. And so it seems in some ways technology could be the solution, but it's also part of our challenge today. And especially when it comes to this issue.
It's not the technology, Raj, that is the challenge. It's the law and the accountability framework. If you lie with using a technology or just lying like that on simple old radio, and you can get out with it, that's the problem of the law. If you lie using a technology and you are catched and you pay the price of the people you kill with this, that's the problem. So the problem is not the technology. The problem is the legal framework.
Yeah, and that's obviously something you in Rwanda know a lot about, thinking about radio and the way people can spread lies and how damaging they can really be.
The genocide. Yeah.
Do others want to chime in on this question? We've had a follow-up to it, which is basically about how do we nurture this trust? We're all saying that's really important. But when you have a healthcare system in some countries that's broken, today we have an in-depth piece about Tanzania, the mixed messages that the government there is sending about the virus. How do we nurture trust in this environment?
If I can go, maybe I would just say we need to start from the very top. We have had leaders in the world, and I often look at the Prime Minister of New Zealand, Jacinda Ardern, who have been built the entire response to a pandemic in their own country on trust, on listening to people, and then responding to the questions and understanding what the fears were and trying to address all people. There are very few leaders that have spoken to children, adolescents, and it's absolutely critical to do so. And we are seeing now in how the epidemic in some countries is being spread by youngsters who are not actually adopting the norms, and then that is having massive effects on older population. And I think the ability to listen is the priority number one, and needs to be starting at the very top. And you have modeling that start at that level and then comes down through the levels of government, and then it should be present at the community level. That's where we have our volunteers out. Something that we have tried in DRC during the Ebola outbreak in North Kivu is the introduction of feedback mechanism. We have our volunteers entering the communities. They collect their fears, their doubts, and we analyze. We did that with the CDC, and we map what the main concerns are by location over time. And then we adapt we change the approach based on the feedback that we have received. And then we go back and we see whether these concerns have actually decreased. This is a feedback loop that I think is absolutely critical and needs to go down at a community level to build that trust, to see that people are not only listen to, but the people who are listening are actually acting on that. It goes back to the point of accountability that Agnes made, and it comes from the service providers who need to be accountable to their clients, because I think they're not beneficial. These are clients that deserves services that have a human right to health that needs to be fulfilled.
The other thing, Raj, is participation. You listen, you respond, you adapt your speech, make sure that you are understood, and also you make people participating to the response. And if you do that, they will know what is planned and they will follow you.
It's amazing how in this crisis, we have really seen the importance of behavioral science, right? I mean, it's something many people have spoken about in the global health field, but boy, if you look at the countries that are doing well, it really does come down to these kinds of basic things. Emanuele talking about a leader speaking to children, it might sound like a small thing, but the countries that have done that, and Bill Gates mentioned this recently as well in an interview, that because of the exponential nature of the virus, relatively small changes at the right moment have a very big difference in outcomes. Yeah. And you can see that across countries, the outcome differences are dramatic based on what seem like pretty basic, small social determinants, talking to people, giving them a chance to understand an issue. I think, Mickey, you wanted to get in on this question.
Yeah, and I want to complement what Agnes and Emanuele said, but also point out that the way you build trust is also the way in which your system is set up and established. And so two systems in particular I want to draw attention to is one is how you finance your health system. And so, if you have a fair financing system where, it's no payment at the point of care, where access and equity at the heart of your financing process, then I think, those societies have built a far more robust and resilient and highly more trustworthy system than those countries which rely on out-of-pocket, which have two-tiered or three-tiered systems for the rich and the poor, and so forth. So I think looking at how your systems have been set up and are being, and this is maybe an agenda moving forward, is to draw attention to your financing system, but also your HR system. So we still continue to put higher value on urban-centered medical training for highly specialized elite medical professionals, as opposed to what most countries need, which are generalists and community-based and training and capacity in the communities. And those programs are out there, those innovative training programs are out there, but nearly always they are, not got the prestige of the medical school in the capital cities. So thinking about how we value and the messaging we give around some of these key systems also build that trust in a maybe a more sustainable manner than for the more immediate behavioral types of things as well.
I can tell you that one day when we're able to travel again, I would recommend to all of you to get to the University of Global Health Equity in Rwanda, where Agnes is the co-founder and the vice chancellor, because it precisely tackles this question. It brings, university students who are, the best of the best, brilliant people, but says, hey, come out and live in a rural area and learn what it's like to do health for people in these communities. And it changes your perspective completely, right? And it addresses a lot of these social and status questions that you're bringing up. Agnes, please tell us more.
No, I just want to say that this was one of, when I was a minister, you educate doctors when they are, even if they are born in a rural area, they don't want to go back there because they believe their life is finished. They're young, they want a pub, a cinema, their friends, and they don't want to go and work with the people that are the most in need, rural poor. So that's why we decided to put the university in the most remote district of Rwanda. And we have built a state-of-the-art university, but in the middle of the communities. And this is the best education we can give, because our students are capable to go and work whatever place in the world. We treat, it's an international university, majority are Rwandan, but they can work with street young people, drug addict in US or in Papua New Guinea or with Aborigine or in Rwanda, etc., because we have educated them like that with those ethical principles of global health.
Do you think there are other issues like this related to status of healthcare workers? In many countries, we talk about community healthcare workers not being paid, nurses, not being well paid. What do you think of the question of status of healthcare workers? As I said, in much of the world now, including where I live, you see signs, praising and thanking healthcare workers, but we're hearing examples from all of you about how, in many cases, even the basic compensation isn't there.
That's true. And I want to tell you that in Rwanda, we have 4 community health workers per village. We have around 15,000 villages. The community health workers are elected by the village, but agree to be volunteers. However, they are awarded by performance of what they do. They treat, they diagnose, they transfer. This is this amount of money they will receive for service rendered. It's not a lot, but it is something because we don't have the money to do more. And when people, when I came in this country in 96, you know how much I was paid a month? $75 a month. Huh? And I was accepting that because everybody was paid like that. So when you are not happy is when there is an injustice, not when there is a call for solidarity. And our community health worker system is working well. They are not working for free because it's against service rendered, but they are not very well paid. But nobody is very well paid in this country. And the status of doctors from education in those cities where I went to school with some young people at that time who want to go there to make money. I remember the status, we don't want our students to pay because we want to take students who cannot pay. We don't want them to take a loan and spend 25 years to reimburse that because they will run after money, not after the people. So we just say, after your studies, you have to work in a place where you are useful for the vulnerable, whatever place you want in the world, but work for service. You keep your money. And for us, we mobilize the money for you to study.
Emanuele, please.
Just linking back to your point of what will a Minister of Finance do next year when the budget for next year will be discussed. You probably have lower revenues. You have ODA shrinking. What is the minister going to prioritize? And I think this is where we will see the challenge of this pandemic being confronted by decisions. And unless there are investments made on this community health workers, and there are trade-offs, but really investing on that expansion and on the strengthening the incentives, which may start from the stipend, but would also need to go with the health insurance, the hazard pay, the life insurance. Unless these are not put in place, there is a risk that this will remain empty words, and we will not be able to prepare for the future. So I think there is a real policy decision, financial decision that needs to be taken in the future, and maybe between respirators, adding respirators or a CT scan versus expanding your community health workforce, and decision will need to be made. My hope is that we will be able to make a very strong case for investments in expansion of community health level, showing that the return of that investment is very big, and putting protection at the core of our investment, the recognition at the core of their work, of their role in the society at the core of the investments.
And those trade-offs might just get much worse, Mickey. I mean, we've got a lot of developing countries that were told during the Addis Ababa forum on financing for the SDGs, hey, you need to kick in more of your domestic resources. Some have been doing it, many have not. And then you get to a situation like this, a prolonged recession. Countries that are the most vulnerable are probably going to see their tax revenues drop considerably. They're not going to have the money. That trade-off that Emanuele talked about will get worse. You talked about the debt burden that many of these countries are facing. Of course, the G20 are, they're doing debt moratorium. They're suspending some debt payments, but this is a long-term fiscal challenge. It seems like probably the donor countries might need to step up in a much bigger way, Otherwise, those trade-offs could be catastrophic.
No, you're absolutely right. And so we have to double down on this global solidarity message that, you know, we're as strong as the weakest link, and that the investments in health systems in low-income settings is you know, gives you good return, and both for the human rights perspective, but also in terms of just your own safety and security as well. But I do agree also that there is going to be a challenge within countries, because whilst Emanuele is right that community health should be a priority, what we're seeing, unfortunately, though, is you know, most of this is happening in the urban context to begin with. And it's there where the systems are falling apart most quickly. I mean, India, Pakistan are classic examples right now, South Africa as well, where it is predominantly in the large urban settings where the system has been shown, you know, people are just flocking to the hospitals, which are not taking patients. So I do think we also need to think about what an equitable and solid system in an urban context should look like, and what is the role of primary healthcare in an urban context as much as in these more traditional rural areas. So I do think there's an agenda there that we as a global community need to re-engage with in a more innovative and different manner than perhaps we've done before.
Yeah, this has been a great conversation. I'm amazed looking at the time that we only have a few minutes, Agnes. So let me ask you, please add, but we're going to make this the last comments. And we did get a number of great questions in, so I'll just give you a couple of the themes in case you want to pick up on any of this. We're getting questions about gender dimensions. Of course, 70% of frontline healthcare workers are women, but if you look at the leadership of global health, unfortunately, it is nowhere near as equitable as that. Quite the opposite. We've got some questions in about stigma, where you have frontline healthcare workers facing the stigma of maybe being infected with the virus. And then others talking about the broader kind of silo questions around the way our industry is set up, and whether there's opportunities to break down those silos in this moment. So look, we're not going to get to all of that, but in the final minutes we have, maybe just a closing thought from each of you on any topic you'd like to bring to the table. Agnes, of course, we'll start with you.
I just want to say that we should stop to look to Minister of Finance. Could we look to the Parliament? Because the Minister of Finance proposed a financial law of the year, the budget. Who voted? The Parliament. So that's maybe the place we should push, because the Minister of Finance just applied the politics of the country. That's what I wanted to add, and I totally agree with the question, but I let my friends here to answer the others.
You're right. This is a political issue now. If this doesn't wake people up and move parliamentarians and others, what will, right?
Yep.
Emanuele, what are your closing thoughts?
Difficult. I'll pick up on stigma. That's what we are seeing a lot, and that requires protection of frontline health workers, which starts with PPEs, but will potentially very soon be with the distribution of a vaccine that may become available. I'm happy to see that the COVAX facility that has been recently launched, that has a very good ambition of protecting 2 billion people by 2021, will start with frontline health workers, and the doses, the first 3% of the doses will go to frontline health workers. And then once again, I want to reiterate the needs to protect financially, and as importantly, the need to protect from the psychosocial mental stress that the many healthcare workers are experiencing now. That is a moral obligation for all of us, and that's what we owe to these frontline health workers, beside the clapping that we all have been doing.
Thank you so much, Emanuele. Mickey, your final thoughts.
Yeah, maybe just to pick up this really critical issue of gender as well. And I suppose another argument that we should be strengthening and making more forcefully to Parliament and to Ministers of Finance is that health sector investments is also an economic and a very productive part of the economy, and an important, and in the West, it's been an important cause of the growth of economies has been the health sector. And in most countries, health work is one of the few should become one of the few well-paid and well-respected jobs that women should be predominant and have been predominating in. So investing in improving the terms and conditions, the salaries, the safety, and the training of health workers is creating employment for women largely, And that has all sorts of important secondary economic implications as well. So I do think we need to really rearm ourselves with those arguments as health, not as an expenditure, but as an investment, not just for health for the sake of health, and not just for health for security, but also as an economic imperative, particularly for women, gender.
Thank you for that. And these are great points. What I take away on this is just how much we know on these topics. You know, I mentioned before how many leaders in global health expected a pandemic would hit us at some point. And I think similarly, leaders in global health have a lot of great ideas about exactly what is required when it comes to the healthcare workforce in the front line. And I hope now is that moment when we take a lot of the knowledge and learning that we have from prior crises, from good examples from countries who are doing it well, and we start to actually apply that, and we can build the movement that's required. So I just want to thank all of you immensely for these great contributions. I know if there were an audience here, we would all be applauding. So please join me wherever you are in the world in applauding these fantastic panelists. Thank you so much for being a part of this discussion. Thank you.
Thank you.
Thank you all.